Dr. Mulholland, let me explain the arrangements. You're talking to an audience here which consists of those who were infected and affected, participants and co-participants. To the left, you have lawyers who represent various different interests in the inquiry. And at the back left, there are those who may from time to time include representatives of the press. But beyond this room, there is a wider audience, both here in Aldwych House and watching on YouTube or live stream. I can't tell you how many quite there will be, but it'll be probably in three figures and maybe substantially so. Ms. Fraser-Button will be asking you the questions, but first Mary has to invite you to affirm. Mary.
Please state your full name.
Michael Niall Connor Mulholland.
And repeat after me. I do solemnly, sincerely.
I do solemnly, sincerely.
And truly declare and affirm.
And truly declare and affirm.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Dr. Mulholland, you're a practicing GP and also the Honorary Secretary of the Royal College of General Practitioners. Is that right?
That's correct.
Can you tell us, in layman's terms, what the Royal College's role and remit is?
The Royal College of GPs is to foster and maintain the highest standards of general practice and encourage that as we move forwards with new generations of GPs.
And as Honorary Secretary, what are your responsibilities?
My responsibilities are mostly around governance of the college and governance to the trustee board, and within that I have roles in supporting the membership team. I oversee the clinical policy on behalf of the officer team as well.
I want to address my next set of questions about the training of GPs, just so we can understand how GPs are trained and what role the college has. So in terms of initial training to become a GP, what role does the college have within that?
So all doctors that want to become a GP enter GP training schemes, and the role of the college within that is we set the curriculum for general practice training. We also oversee the exam at the end of general practice training. And to become a GP, they then go through 3 years of GP training that is overseen by the statutory education bodies around the four nations of the UK. But we bookend that training process with curriculum and assessment.
And in terms of those exams at the end, by passing those exams, then a GP is effectively allowed to practice in the UK as a GP?
Yeah, passing the MRC GP exam, the Member of the Royal College of GPs exam, is also used as a marker to get your certificate of completion of training, and that then is looked at by the GMC as the marker that you can then be practiced as a GP specialist in the UK.
In terms of training on communication skills, can you explain for us what's required by the Royal College before someone is signed off, licensed as a GP? So
communication skills come into the whole of the exam and the tripos. We have a 3-part exam, which includes clinical skills assessment, our communication skills assessment. We've got workplace-based assessments and a knowledge test as well. Within each part of that, our curriculum has parts that will be tested in each stage. The most obvious one, looking at it, is the clinical skills testing, where communication is observed either in the workplace by the GP trainer or by assessors during the examination. And that's a core part that a trainee must pass both the WPBA, the workplace, and the communication skills. And just broadly, when you're assessing communication skills, what must a trainee demonstrate before they are passed? What is the college requiring of trainees? So our communication skills in the assessment has been looking at particularly that they must have a knowledge, they must know what they're doing and do the right clinical management of a patient. They look at the interpersonal skills, and the third one has skipped my mind, but it's generally to look at how well they communicate their ideas to the patient and understand what the patient's ideas are as well, and take them into consideration as they have a whole assessment of their care.
I think you also talk about the attitudes, feelings and biases.
Yes.
Is that part of it?
Yes, that's part of it, and that we test it not only in those clinical skills videos or simulated situations they're in, but also during the case-based discussion work they do during workplace-based assessment. A trainer is able to then explore a case that they've gone through and then ask them specifically about how they have managed those cases and what their attitudes were during it, and make an assessment based on that. So,
and in terms of Wales, Scotland and Northern Ireland, what's the position in those three nations? Is there a difference?
there isn't a difference in terms of the assessments. It's a 4-nation exam that we run.
How much, you described the Royal College bookending the initial training, but the training itself being done, I don't think you used the word when you were giving oral evidence, but in your statement you talk about deaneries doing the actual training. First of all, can you explain what a deanery is?
A deanery, within the UK, there are 4 statutory education bodies, one for each nation. In England, it's Health Education England. They then divide into regional bases of deaneries, and I think there's 14 of them in the UK across it. And the deanery then looks after a proportion of trainees that are closely related to the practices in that area.
How much interaction is there then between the Royal College and the local deaneries as to what should or shouldn't be included in the training that's given?
So the curriculum is there that the deaneries are training to. What we then get involved in is not actually what's being trained in, but how the assessments are quality assured. So we don't get involved in that training part. That is left to the education bodies for themselves.
And then once somebody has qualified as a GP, what role does the college have in relation to continuing professional development?
So as a college, we, in common with the other medical Royal colleges, we provide education materials that GPs may turn to, or our members can turn to. Sometimes we provide materials for everybody that can access freely. Other times it's specifically for our members. But we do not say what anyone should be learning in that year, because it relates very much to where a GP is practicing, where their knowledge gaps are, what they need to know more of, and that will be determined between the GP, often at their appraisal. They'll discuss it with their appraiser, what they might be doing next. So we provide the resource, but we don't have any say over what people do and who uses it.
In terms of the resources you're providing, what sort of material is provided? What sort of topics does the college provide material on? As
a generalist college, we provide material on almost everything that can be covered across medicine, or the widespread of it. And we provide it in different formats. Sometimes we do webinars, and they've obviously become very popular during the pandemic as we all turn to electronic means of communicating. We do have face-to-face courses. We also have what we call our essential knowledge updates, which are providing up-to-date knowledge on a quarterly basis that people can work through courses. And then there's a range of CPD presentations and courses that you can go on online from it.
And how are new CPD resources provided or new topics chosen? What's the process that is followed?
So the college has a CPD strategy group that sits underneath the Vice Chair of Professional Development and Standards, and they work through where they're hearing both the needs of new things that came up. So obviously when COVID came up, it was an immediate need that we needed to swap all of our CPD resource to COVID for several years. But also we then have experts or specialists around the country that will feed in that these are the new things happening in women's health or in infectious disease, whatever comes up that is topical and new that they will try to put in. And so the strategy group put that in through the courses and through the conferences.
The inquiry's heard evidence from a number of female witnesses related to their hepatitis C being undiagnosed by GPs for a period of time, and their symptoms being put down to motherhood or perimenopause or menopause and then old age. Does the college's CPD material deal with anything around equalities and discrimination?
Yes, I think in everything that we've done, we've looked at where equality sits and whether it's in our curriculum, where we teach all the way through, the importance of looking at biases that can come into thinking and in decision making, not just about the clinical diagnosis, but about the people that are in front of you, where you have unconscious bias there. But also then in our materials, the teams are conscious of what they're doing and how they fit them to make sure that it is not discriminatory, that it does include everybody, and that any biases that might be present are addressed during the CPD learning.
And I'm asked to ask whether any of your materials covers listening to female voices, particularly in relation to their symptoms and when they're experiencing pain, and how a woman's experience of illness is understood.
I don't know specifically on that. I'm sorry.
And do you have any materials in relation to race discrimination as well?
Yes, there are.
Can you just tell us a little bit more about what work the college has done in relation to that?
So it's become a significant part of our college's work on how we address race discrimination. Over the past few years, the college has been working on both the equality, diversity and inclusion of our membership, as well as our patient groups as well. So there's been a task group led by our chair and our COO who have led this through the college. There are materials being put out. Our CPD, I know, has got a new module recently on unconscious bias. Our curriculum is being reviewed completely to make sure there are no biases within that, and it's gone on in every area of the college that we have.
We've obviously discussed the provision of materials by the college, but there are also commercial organisations who may also provide CPD materials. Yeah. Is that right?
That's correct, yeah. And many GPs will go to commercial organisations as well. We have 54,000 members as a college. There are many more GPs than that. And so some people will exclusively use commercial providers as their CPD resource.
And does the college have any involvement or oversight of those CPD resources that are provided commercially?
No.
How is the continuing professional development of GPs monitored? You spoke a moment ago about appraisal. What's the system involved there?
So annually, each GP has an appraisal with an external appraiser who has been appointed in England by NHS England, who reviews with you your practice. It's usually a several-hour discussion. Before the pandemic, it relied on you providing an awful lot of evidence to show what you had done. That is less so since the pandemic. They've changed the model during that time. But your appraiser is there to check the areas of your working, that you're actually doing CPD, that you're covering the areas of concern. If you had any complaints or health issues or anything else, those would be discussed during your appraisal as well.
So in terms of identifying a need for CPD, that there is an area that perhaps the GP needs some input on or some training on, how is that identified?
That often we identify through self-reflection, the way they work, that you would recognise that you have patients or problems that you've not been able to identify for yourself. And that's all part of the GP training, that we encourage people to be very mindful of what they do and don't know and reflect on each patient and the gaps in their knowledge there. But during your appraisal, it's often a time where you've also got, every 5 years, patient feedback and colleague feedback to add into that. And from that, you may find there are other issues that have come up, sometimes around not so much clinical issues, but other skills that you may or may not have, and those would come into the appraisal and to your CPD at that point.
Given that flexibility of GPs essentially trying to work out what they themselves need to be trained on, is there a risk that some GPs may not receive the training that objectively they do require?
Yeah, I think that's fair, that we never know all our unknowns, and they come up, and what we try to train people to do is to understand that to make that a smaller and smaller part of their knowledge, that with the feedback that we get and patient feedback very directly in practices, when you're working in teams, you become aware of what others think your gaps may be, and then you spend the time doing the work on that. But yes, there's always a risk that we won't know. As GPs, we don't know everything. We try to cover as much as possible and are aware of the curriculum, but there is a risk.
In relation to communication skills, how is that addressed within the appraisal process? That
probably mostly comes in from the multi-source feedback and the patient feedback that we get on a 5-yearly cycle as part of revalidation. The patients are asked specific questions about your communication and how much they understood, how much you communicated, and how they felt about the consultation. Did they get the information required? And that's probably where it's assessed most objectively on a 5-yearly basis.
And that would then be discussed with the appraiser?
The appraiser discusses that with you afterwards.
If there was a concern that a GP perhaps had entrenched attitudes or an unwillingness to adapt familiar practices, rather than needing new knowledge, if I can put it that way, how does CPD address that sort of issue?
At that point, if the appraiser was picking that up, they would probably guide you in your professional development plan for the following year to focus on that area. Because we have appraisers often in many areas for 2 or 3 years, they would be often coming back to it the following year to check, had it been done, what had been done, had you got new evidence? And sometimes appraisers will ask for further evidence that an area has been covered if they felt there was a significant weakness in that.
And what resources are available or training programs that are available to somebody who is faced with an appraiser saying, actually, there are issues here that need to be addressed, that aren't a knowledge question, it's
There are
an
often
attitude
courses
question.
available for that from commercial providers or from the college on other skills, whether it is bias training or that sort of thing. It can be picked. There are courses there that doctors can access.
And carrying on the same issue, if the appraiser has recommended something and the GP has not then engaged with that issue, what is the process then?
That's probably beyond my knowledge. I believe it goes towards the responsible officer for the area, who then can address it.
So it would be escalated?
Escalated.
The inquiry has heard about a number of guidelines that have been introduced over time and that there are a substantial number of guidelines coming in all the time. How are GPs, starting off in England, how are GPs in England kept up to date with new guidelines?
With GPs face so many new guidelines coming often from specialist colleagues that it's very hard to keep up to date with that. There are many publications that will summarise guidelines and receive them in the post. The college tries very carefully in our CPD approach to inform GPs of new important things. Our clinical policy team works on that as well as the CPD teams. The organisations like NICE, the Institute of Clinical Health and Excellence, do send out emails regularly to tell us new guidelines are coming. So there's a wealth of places they come from. Choosing which ones you need to see is the harder part because there's so many to know whether they relate to your primary care experience is difficult.
And how does it work in Scotland? Are you able to assist with Scotland, Wales and Northern Ireland at all?
Probably no more than my witness statement.
Very well. For those listening, the witness statement reference is WITN 7249001 and there is material there. In relation to how best practice is embedded into GP practices to ensure that on a day-to-day basis best practice is followed, how does that work for GPs?
Each practice will have their own systems and ways of doing that. As a college, we encourage quality improvement activity and have seen that going into our QOF assessments as well as into the training. And so quality improvement activity also falls into our appraisals, and each year quality improvement is something that GPs try to show that they've done. So that would be how we try and embed new things into practice to audit, review and improve the care.
And moving out to being more specific in relation to hepatitis C, what can you tell us about the work that the Royal College has undertaken to increase the awareness of GPs about hepatitis C? Since
2006 or 7, I believe, the college has been actively producing guidelines and information for GPs to update them from when hepatitis C was a newer disease and not known as much. The college took a leading role in developing that and has updated guidance ever since to try and keep GPs to the fore of it. Hepatitis B and C we have modules on and learning CPD resources. And those have been provided and updated to 2021, I think was the latest review we've done of them.
If we could turn to the guidance that the college produced in relation to the prevention, testing, treatment and management of hepatitis C in primary care, WITN 7294006. I'm sorry, 7249006. Apologies, I've got my numbers wrapped the wrong way. We can see it's the Royal College of General Practitioners guidance. And if we turn to page 3, we can see the contents page setting out broadly what the guidance covers, including information about what hepatitis C is, the natural history of it, making the diagnosis, testing in general practice, referral, and then over the page, treatment. And if we can then carry on to page 11, please. We can see the heading Transmission of Hepatitis C, and further down we have the subheading Blood Transfusions and Blood Products. Prior to the introduction of screening of all blood donations in 1991, there was a risk to recipients of blood. A heat treatment process to protect blood clotting factors used in the treatment of haemophilia against hepatitis C and other viruses was introduced in the mid-1980s. Treated factor 9 available in 1985 and factor 8 in 1987. There is a high prevalence of hepatitis C in people with haemophilia who received untreated clotting factors before these dates. However, hepatitis C should still be considered in patients from overseas or who've travelled abroad, who've had blood transfusions or surgery. This paragraph might be read as having a particular focus on those with haemophilia and those receiving treatment abroad, with only a relatively brief mention of those who've received blood transfusions in the UK prior to 1991. Could you help us with why that emphasis might be there?
I think this was the 2006-7 guidance, and when I wasn't part of it at that stage, whether that was the extent of the knowledge. I know that in the more recent documents that we've published in the learning modules that there are, it focuses much more on blood transfusions as well.
I note in passing that in the middle of the second last sentence on the page says there's a high prevalence of hepatitis C in people with haemophilia who received untreated clotting factors before these dates. In other words, before 1985 and 1987, so far as factor 9 and factor 8 were concerned. I wonder whether that is strictly accurate, Ms. Fraser-Butlin, because the evidence that the inquiry has is certainly there was a product in England produced by BPL which was effective in respect of eliminating hepatitis C, non-A, non-B as it was called at the time. But that didn't mean that commercial products, which formed round about half, if not more, of the products supplied, had the same protection. And it ought not to be thought, I think, ought it, Ms. Fraser-Butlin, in accordance with the evidence that we've heard, that commercial product was free of hepatitis for some time after that.
Absolutely, sir. And that was you preempted a further question that I was going to raise of whether why those dates had been used. And
what does the footnote say?
If I can just take a moment, footnote 41. It refers to the Lancet study of 1997 by Darby, Ewart and Jan Grande and others in relation to it's the Haemophilia Centre Directors Organisation, mortality from liver disease in haemophiliac men and boys in the UK. So it doesn't, it just takes you to a reference, but it doesn't deal with that issue that you have raised, sir, as to whether that is actually an appropriate date.
Yes, thank you. But I don't know if that's been corrected in recent editions, or is this the most recent edition?
No, that's 2007, which was the first information that the college had produced on hepatitis C at that stage. So I'm sure in more recent editions it's been corrected, but I will look to make sure.
Well, you're sure?
I will make sure it is.
You will make sure it is. Thank you.
Just staying with that paragraph, and that emphasis on transmission in relation to those with haemophilia and transmission where blood has been received abroad, do you think that that is the understanding of many GPs, that that's the primary issue of blood transfusion and blood products and transmission of hepatitis C, rather than a significant awareness of those who have received blood transfusions in other circumstances, in terms of obstetric care or trauma or something like that?
I think today people are much more aware that of blood transfusion, having been somewhere that patients received the blood and it was infected at the time. So I think the knowledge now would be much greater than it was, whatever that was, 16 years ago, 15 years ago, that it's much more widespread and UK-centred, and it's an issue for GPs to be aware of.
But even as relatively recent as 2007, would it be fair that perhaps the emphasis wasn't on those who had received transfusions in the UK?
It would appear so from this.
Could we then turn to page 15 of this document? And we see the heading, who should be tested? And it says this: the following people should be offered a hepatitis C antibody test. It's good practice to offer HIV, hepatitis A and hepatitis B testing along with hepatitis C after the appropriate discussion. And then at number 4, we see recipients of blood before 1991, or blood products before 1986 in the UK, and or organ transplants before 1992. So the same issue about the dates arise. And then number 12, consider any patient with abnormal liver function tests, LFT, especially elevated alanine aminotransferase, ALT. In terms of the recipients of blood or blood products, it might be suggested that this would assume someone knew that they had received blood. Was there any recognition then, and is there any recognition now in relation to the problems with medical records showing someone's had blood, and indeed the knowledge of a patient who might have been unconscious, whether they've had blood?
I think there's an awareness now that blood was given in a different way in the 1970s and 80s than it is now, without the very strict tracking of where blood has come from and who it's gone to. And I think we'd be aware that in our older patients, they may not have knowledge of having blood during surgery or other procedures at the time, nor would GPs have been aware that that necessarily wasn't being transferred to us through records.
And in terms of the point 12 of considering any patient with abnormal liver function tests, when as a GP would you consider testing, or is the Royal College guidance on testing a patient when they have abnormal liver function tests?
Yeah, I think we would now look at the NICE guidance. That's quite clear on when you should be testing and when you should look at an abnormal ALT, and the tests that should be following it, one of which is hepatitis screening, but also ultrasounds and tests. The more common things that will produce this in patient groups include fatty livers and alcohol-related disease. And so we would have those in that screen as well as ultrasounds and hepatitis screening.
And then if we turn on to page 28, please. We see the heading ongoing care. And we see a subheading, sorry, if you just go down to the bottom of the page, please, Lawrence. We see the heading ongoing care, and then a subheading ongoing care during treatment, usually in hospital. And so there's a discussion there of blood tests, ongoing advice regarding injecting medication, ongoing support, and then the next column, please. Ongoing review / care after treatment, with the relevant PCR testing. And then the next heading, in general practice. There are a series of points dealing with support of a patient during their treatment for hepatitis C. Provision of ongoing general medical services to support the patient through the treatment process. Supporting patients on therapy, giving practical advice to them on managing side effects, ongoing support, ongoing harm reduction information, etc., and some points about referrals. It appears from this guidance that the ongoing care in general practice in relation to hepatitis C comes to an end when someone achieves a sustained virological response. Is that fair of what the guidance suggests, or is there guidelines about what happens to the patient after they've achieved a sustained virological response?
I think the treatment for hepatitis C has changed so much in that time that our awareness and the hepatology units, the secondary care colleagues, we would refer very quickly. The management of that disease tends to sit with our secondary care colleagues until they have reached an end point, which I think these days would not just be on viral clearance. We would then get information back as to what follow-up was required in primary care or in secondary care as well. The main bit that stays with us and has always been there is the holistic ongoing care of the patient who has ongoing health needs. So that stays with general practice, and often that involves the support in managing day-to-day living as well as psychological and everything else that we do as part of a GP service. But the disease itself would now be managed in secondary care.
And so you've indicated there's up-to-date guidance, which so I will ask those in the team to identify and ensure that they are available on relativity as soon as we can. And you've discussed some of the education materials that have been produced. Is there any other, have there been any other measures taken to increase awareness of hepatitis C?
I think in each of the countries around the UK, the RCGP has done different things. Within Scotland, where they have a high IV drug use population, where hepatitis C is more common, they have done specific Scotland-related initiatives. Beyond that, I'm afraid I don't know.
Has there been anything else in England that you're aware of?
Not that I'm aware of.
Could we just go back to the very first page of this document? Because something caught my eye in passing, which I may want to ask a question about.
Of course. So did you mean page 1?
I
or
do.
did you mean the page that we looked at?
The cover page, yes.
The cover page.
I don't have the question, I think, anymore. It arose, let me tell you what it arose out of. The prevention, the document is prepared by the bodies set out there. And the first one caught my eye, which was the RCGP Substance Misuse Unit, and then the Sex, Drugs and HIV Task Group, which obviously someone's got to write it, but it might suggest, particularly given your reference to unconscious biases, that someone, not yourself I suggest, but someone reading this might think, oh, this is about this sort of area. Whereas at this time, in 2006, it wouldn't have been, really, would it? It might have been more by way of intravenous drug use, but certainly there would be quite a large component from those who had been infected by blood or blood products.
I think at that time, I was talking to our president, Professor Dame Claire Gerada, yesterday about this paper, that she was one of the those that was involved in the drug misuse unit at the time, that was where the focus was. It was in the IV drug use population where hepatitis C had just become a real issue for them at that stage, and we were understanding it, and this was the first time GPs were being given information around that, so it did focus on this area. I think at that stage the awareness of it being a blood transfusion as being a major contributor to hepatitis C wasn't there as much at the time amongst the general practice side anyway.
One of the side effects of that would be that when patients came in to see a GP, they might be faced with, well, what drugs have you had, what alcohol have you been taking, that sort of approach, rather than asking questions about transfusion.
Absolutely.
The next series of questions I want to ask you relates to what might be said in submissions to this inquiry, that there remains a considerable knowledge gap for many GPs about hepatitis C, and there are a series of scenarios I want to discuss with you. one issue that's been raised is that sometimes someone might present to a GP over a period of time with non-specific symptoms and mildly deranged liver function tests, but hepatitis C testing doesn't follow for some time. What could be done to improve the knowledge and awareness of GPs about the need for testing for hepatitis C? Or do you think that issue has now been addressed?
I think the awareness will be greater now, that people are aware of hepatitis C as a disease that's been transferred in blood transfusions as well as through intravenous drug use. There are always a need to increase the knowledge of specific diseases, of which as a college we hear many all the time of things that where GPs have taken time to recognise disease. But I think it's something as a college we're aware of, particularly me attending today, has focused our minds on where we sit in that blood, in making GPs aware again of hepatitis C. I know my Scottish colleagues have done more recently because with drug use in Scotland it has been more of a problem that they've needed to inform their members because it was something they were all seeing all the time. How we do that, I'm not sure at this moment, but certainly something we can consider as we move forward.
Another scenario might be where someone has gone to their GP and asked for a test for hepatitis C. The inquiry has heard evidence that in some circumstances, some GPs have either said it was unnecessary or said that if the person had received an infected blood transfusion, then they would have been identified in the look-back exercises that had already taken place. The inquiry's also heard evidence about the limitations of those look-back exercises. What could be done there again to improve the knowledge and awareness of GPs about the issues surrounding infected blood and the limitations of previous look-back exercises?
I think doctors in general now are much more aware of the risks of infected blood, not just for patients, but as we've gone through hospitals during this time of needle stick injuries, everyone's very aware that the screening for that includes hepatitis as well as HIV and other diseases. So I think we're aware of bloodborne disease as a real concept when maybe 15, 20 years ago it wasn't in people's minds as much. The look-back exercises, general practice records are very good, but only very good with the information that general practice receives. And so if blood transfusion will not be given in primary care, except in very specific military circumstances, I'm told. But so what we rely on is the information coming to us and coding it. One suggestion I was given this week is that on the electronic platforms that we do our consultations on could have as part of the onboarding for a new patient and their new patient screens, not just what your weight and your alcohol is, but have you ever had a blood transfusion? So some of those might improve that.
I want to come back to that thought in a moment. My question was slightly different in that how could, what could be done to improve the knowledge and awareness that look-backs weren't perfect in the past, there were limitations. And so perhaps to address the issue of where a GP might say to somebody, don't worry, if you received an infected blood transfusion, you'd know about it. What could be done to address that scenario?
I think that's probably an issue beyond general practice, that is information to the public at large, not just doctors, that look back wasn't as effective as we might have perceived it to be, and being aware of those limitations to it. That's something that could come to doctors, to be aware that your look back exercises weren't quite right, or could come to the public the other way around, so we're all aware of it together. But I think that's not knowledge GPs would necessarily have without somebody informing us that the look back hadn't been as accurate. And
thirdly, in terms of evidence of people who've had treatment for hepatitis C, they've achieved a sustained virological response, but they continue to suffer ill health. The inquiry has heard some evidence where GPs have then dismissed those concerns because they've reached a sustained virological response. Again, what could be done to improve the knowledge and awareness of GPs about the ongoing health issues that arise from chronic hepatitis C, even after having sustained a virological response?
I think some of those are dealt with in the newer CPD modules that I've looked at recently. I think that awareness of hepatitis C as being a disease that is there with long-term sequelae to it is something that we could work out through the CPD side. I was just thinking of the first question you asked me about the person coming with the non-specific symptoms. And there's so many non-specific symptoms that present to general practice every day that the diagnostic process is based on step-by-step working through them. And it is that awareness that when we get the abnormal result, it is time to do the next step. And hopefully in our more modern publications, we do have that the raised ALT goes ahead to the hepatitis screen.
There's obviously a wide range of resources that the Royal College is providing in terms of CPD. In light of, it might be submitted in light of the ongoing difficulties, evidence of ongoing difficulties in terms of GPs having that awareness, it might be suggested that this is a cultural issue rather than a question of more education. What can be done to change the culture of how GPs operate?
Can you be more specific on the cultural issue?
That although resources are being provided, change isn't necessarily happening on the ground. I think it is a general question of how does one translate CPD and knowledge into change on the ground?
I think because of the nature of general practice, each GP will probably have a different set of learning needs each year. To mandate that every GP in the country would do hepatitis C training each year, or even once in the next 5 years, may mean that many GPs that don't see hepatitis C as part of their workload, because their patient population is different, don't do the training, and the others that really need it maybe beside for 3 or 4 years. So we tend not to mandate anything specific except resuscitation training and safeguarding training as the two things that we do every year or every few years as part of a requirement. But everything else is hopefully through the appraisal process and a GP's reflective behaviour picked up and done that way.
But in terms of those who may have been infected through a blood transfusion, would it be fair then that because in their region there weren't so many people who were infected with hepatitis C through other means, intravenous drug use, their GP might not perceive there to be a need for that training?
I think with the current awareness, and I suspect from the college as we put it out again, that I've been here and will be informing members of that hepatitis C will rise up, and the importance of checking through or reviewing patients that have had a transfusion in the past when you've got it on the records, or with patients, if they tell you about it, that hepatitis C is one of the risks that will have been coming through that, and we should be checking them.
From your perspective, how effective are financial incentives such as quality and outcomes framework payments at changing practice in general practice?
I think that's probably one for our policy team rather than for myself. The QOF payments are there. I don't think there's any good evidence on how effective they are for any GP to achieve change. People strive to provide quality, and in fact, when we had quality improvement modules as part of the QOF, the college supported them as a way to move them forward, but actually looking at specific areas rather than just getting points for numbers.
And could you see a case for incorporating hepatitis C testing or hepatitis C related outcomes into a framework such as the QOF framework?
I think that's probably beyond the college's remit.
And can you see a justification for assessing or spot checking GPs for having undertaken hepatitis C CPD?
No, I think it's probably the answer that I think if we were specifically focusing on one disease, it will mean that the GP is doing something different and may miss other real learning gaps they have at that time. And it's hard to know where that process would stop. Would we spot check on every disease and see had we covered it? We'd hope through the appraisal process, again, that would be picked up if there were gaps that were significant.
And finally, in terms of obviously today we've been talking a lot about identifying individuals who've been infected with hepatitis C by infected blood and blood products, but who haven't yet been identified. Practically, what would the issues be, both positive and negative, of having a mandatory requirement that patients over a certain age are asked if they have had or suspect they may have had a blood transfusion in the past, to then enable them to be tested?
I think the biggest issue that springs to mind is resource and how that would fit into what's an overstretched, under-resourced, the workload that would come with that. I think that would require an additional service as well as, in addition to general practice, to actually have the resource to be able to do all these tests and follow up appropriately. Because inevitably I would feel you'd pick up patients who have positive hepatitis C that didn't know about it, who would need the time and the expertise of someone to go through that with them, rather than just being told you have a result that we've picked up in a test. It's not the same as the screening programs that do go on have all been approved by the National Screening Committee, and they have the resources behind it to support the patients that have positive diagnoses. And I think if it was just as a mandatory requirement for general practice, there would be no guarantee that support and the systems were there alongside it if it came along.
So those are the questions I have for Dr. Mulholland. I obviously just need a short break to ascertain whether there are any further questions from the recognised legal representatives.
How long do you think you might need?
I think probably just 10 minutes, so call it 15.
We're getting close to the first
are.
afternoon break, so let's roll the two together, shall we?
Yes, of course.
And allow people to have a cup of tea if they want. Let me explain, Dr. Mulholland. Those who are core participants and are represented have a right through those legal representatives to have questions put to you by counsel after hearing your evidence. Plainly, they haven't heard it all, or haven't had a chance to reflect upon everything you've said just yet. They will in the next 20 minutes or so. I can't say how many there will be. There may be a number of questions, there may be very few, but we will say not before 3:20. We'll come back. If it's any later than that, it'll be because there's a late question coming in, and you'll be told. But otherwise, not before 3:20.